Greetings and welcome to today's MHA alumni webinar, Medicare on the Brink. I'm Heidi Mastrud, Director of Alumni Relations at the School of Public Health. Thank you to alumni, students, and friends of the MHA program who've made time to join us live today. The webinar is hosted by the MHA Alumni Association, planned by the MHA Education and Engagement Committee. We offer this webinar to encourage and provide lifelong learning to both local and distance alumni, and we plan to offer more in the future as part of an ongoing series. I've go over a few items so you know how to participate in today's event. Join the presentation listening using your computer speaker system. And you prefer to listen over the telephone, select telephone in the audio panel of your GoToWebinar panel, and then information will be displayed. If you have audio difficulties while listening via your computer speakers, this can be caused by having multiple software applications open, which up your computer's bandwidth and affect network performance. A wireless signal may affect performance as well. To close any unnecessary applications on your computer. Welcome, and you may submit them at any time. Please type in questions in the questions panel on the right-hand side of your screen under Q&A. We'll be answering questions along the way, so submit your questions or comments at any time. I introduce you to the presenter of this webinar, John Christianson. Dr. Christianson is the James A. Hamilton Chair in Health Policy and Management at the University of Minnesota School of Public Health. His interests include evaluation of treatment processes, competition and competitive healthcare markets, health insurance, and financial incentives in healthcare. He teaches courses in the MHA and executive MHA programs and on a number of university School of Public Health, Division of Health Policy and Management committees. In addition to his university responsibilities, Dr. Christianson is Vice Chairman of the Medicare Payment Advisory Commission, established by Congress to provide advice and recommendations on Medicare provider payment and policy. He served on the commission since 2013. Welcome, Dr. Christianson.
Thanks. I'm that you're all willing to sit through a discussion of the future of Medicare during your lunch hour. I appreciate that. So I've been recent students in the program have various earlier versions of this, but obviously everything gets updated with the Trump administration. So hopefully this will retain your interest. I was thinking when we were setting this up that next I'm going to be giving a similar talk to our MHA current students, our day students. And I just want to let you know, some of you may have been in that class, but I wanted to let you know that we have a fabulous new group of students this year. We all joke about best class ever. This group is great, and so I want to thank you all for your donations over the years to help scholarships. Scholarships are critical in terms of great classes, and we have a great class this year, really exciting. So let's get started here talking about the Medicare program. I need to start out by saying that anything that I say about Medicare doesn't represent the views of the Commission. So just a few slides here giving you a sense of what the Medicare Payment Advisory Commission is, and obviously my views are informed by what I've learned by participating on the Commission. It, as Heidi said, a commission established by Congress. It's national since the early 1990s. Not something that was set up as part of the Obama administration ACA reform legislation. Been around for a while. Nonpartisan. So notice that I'm not saying bipartisan, it's nonpartisan. And that's key to its success. It has a lot of credibility in Washington. It's where staff people on either side of the aisle can come. And a nonpartisan view of proposals in Medicare. As you can imagine, anybody working in Congress gets lobbied 24/7 by different interest groups, and they really appreciate any group on to provide them a sort of unvarnished, nonpartisan advice. And that the Commission MedPAC has been able to do for 15 years, and that's the key to its credibility. If we were ever perceived as being either pro-Republican or pro-Democrat, the usefulness of the Commission would pretty much at that point. A few set of principles related to Medicare payment, and I won't read through them. It's a diverse group of people who participate on the Commission. Some are healthcare executives, some academics like myself, some are, and so this is actually a slide here with the Commission members of the Commission last year, to give you a sense of some of the diversity. The chair right now is Jay Crossan, who used to run the physicians for across all the Kaiser health plans in California and nationwide. Products, we hold public meetings. Just got one that was last week. We debate public what our advice is that we're going to give Congress about changing Medicare policy. We're also mandated to advise payment updates every year. Mandated reports that we have to produce, and we have ongoing responsibilities providing technical assistance to different members of Congress and their staff. And the impact of the PAC is probably best given by a couple of things. One is recommendations actually eventually turn up into legislation or into administrative changes in the Medicare program. And this year, we'll be making recommendations that will pop up in legislation 3 or 4 years down the road. And shape policy conversation. A couple of meetings ago, and then again this meeting, we reiterated that we thought the MIPS part of MACRA, for those of you who follow the physician payment under Medicare, is beyond redeeming, and we recommend that it would be eliminated and started over, which is very controversial because this is one of the few pieces of bipartisan healthcare legislation that's passed Congress in the past few years. But we just felt there was no there, and it just really needed to stop before it got fully implemented. So that's the things that we do. We say stuff that other people may be thinking but don't feel they're in a position to say. So with background on the Commission, let me just go forward. Oh, I should say before I go forward that when I'm able to devote the time, and this is a very time-consuming task, to the Commission is because of the donations that alumni made in the past on the James A. Hamilton Chair. And without donations and without the funding associated with the chair, it would be very difficult for me to spend the time that I need to on the Commission. So thank you all again for your donations. So, a brief description of Medicare and what it is. I'll go through this quickly because I see this is not news to most of you. It's a program. It's going to reach $1 trillion a year. Before we know it, we're $500 billion a year now. So when you have a program with this much money involved, it's got a lot of politics associated with it. It's varied by the general public. The quote in the letter read by President Obama, somebody him about opposing the Affordable Care Act, and so he did this letter in a press conference in 2009, and I don't want government-run healthcare, I don't want socialized medicine, and don't touch my Medicare. So the support for Medicare across the board among the constituents and members of Congress. It's also polarizing. It's about 15% of the federal budget right now. So obviously, any legislation that affects the budget is going to involve Medicare. In terms of how we're going to pay for this new program, well, looking at Medicare as a source of payment has become the routine for Congress. They expose some pretty basic philosophical differences. So here's a quiz for you. When the Medicare legislation was being discussed, is what public figure warned that if it were passed, you are going to spend our sunset years telling our children and our children's children what it was once like in America when men were free? Let's come up with your answer. You guessed Ronald Reagan. Before he ran for president, when he was working for the American Medical Association, and the American Medical Association was very opposed to Medicare. He was going to give him speeches like this one. So it's to Medicare, A, B, C, and D, and they don't fit together nicely like the slide suggests they will. And I'll briefly talk about a couple of salient points with respect to these parts that will help set the stage for further discussion later. A was what Medicare was supposed to be. It covers hospital expenses, health visits, over a third of total Medicare spending, and you are automatically receive benefits when you become eligible for Social Security and sign up for Social Security. By employees, we pay 1.45% of wage trust fund. So this trust fund is what's a lot of publicity every year. We hear that the trust fund is going to become insolvent in a certain number of years. It's about 11, 12 years out right now is the current projection. And every fall, late summer, this announcement comes out, and there's a different year that suggests that the fund will become insolvent. So it's kind of misleading. So when we think of insolvent, I think most people think, well, there's not going to be any money available to pay for Part A, but that's not true. Actually, that comes in that year will be used to pay for Part A benefits. So we'd still be able to pay for about 87% of hospital benefits, even if the trust fund became insolvent. And the B, Part B was an add-on. As I say, Part A was really what the initial legislation was targeted for, but it was heavily opposed by the American Medical Association. So they figured out that Part A was going to pass. Said they didn't want to be left out, and lobbied Congress right in the last minute, very aggressively, to include it. And so Congress added something to the bill called Part B, physician outpatient care, some other home health visits, full outpatient care, etc. This is 19 to 20% of Medicare spending. It's voluntary, so beneficiaries don't have to sign up for Part B. They are enrolled in it, but they can disenroll. The key Part B is funded by 75% general tax revenues. So when we talk about budgets, like we've been talking about in Congress now, it affects the general budget, it affects the amount of money that's going to be available to pay for Part 25% is paid for through premiums to beneficiaries. So this puts Medicare right in the middle of politics around budgets and government spending. It wasn't the way that Part A was designed, of course, but this happened because Part B was sort of a last-minute add-on. And then there's Part C, which was add-on to Medicare in 1985. And under beneficiaries can select a health plan they want to enroll in. And the health plan has some flexibility over the benefits that it can offer. So benefits that sign up for health plan typically end up with more benefits, but it has to agree to cover Part A and Part B. And then it was enacted in 2003 under the Bush administration. The president has what we call a compassionate conservative. So one of the primary domestic policies he initiated when he came to office was coverage for drug expenses under Medicare. So, but given the nature of so many therapies for older people, but there was no drug coverage under Medicare. So this was something that he fought very hard for to get through Congress. It was really put a lot of pressure on the Democrats because this had been their issue. They'd been urging Congress to pass coverage for drugs under Medicare. They have a Republican coming in and sort of grabbing their issue away from them and saying, no, that's what we should do. And so President Bush was in the unusual position of really hard to get his own party to come on board with this piece of legislation. And in the deal making to get enough Republican votes to pass it, the legislation prohibits the government from negotiating directly for drug prices for pharmaceuticals. So Medicare is the only public program, basically, at the federal level, that doesn't negotiate drug prices. It does. There's a state administrative program. They negotiate drug prices. Just across the board, Indian Health Service for Medicare. And the usual feature of Part D, but it's explained the usual nature of the politics that went into the passage of Part D. All right, so let's talk about what challenges now face Medicare. And of course, a large number of them, so I'm going to focus my attention on the four that I think are the critical ones now going forward. After we talk about that a little bit, we'll move on and talk about what the future is like under the Trump administration. We classify these challenges under four categories. One is the demographic challenges. This is the pressure to reduce Medicare spending programs. The third is the concerns about the impact of Medicare spending on the federal debt. And then one is the growing divergence between payments and Medicare sector private providers. So two graphs here. The first one is of the enrollment in Medicare because of the baby boom generation. So as you probably heard quoted times is that there are 10,000 new care beneficiaries every day, and this will be the case for a number of years yet. As the baby boom generation ages in Medicare. That looking at that slide, that's as you move from the 47.4 to the 81.1, you can begin to sort of taper off around 2035, resume something like a more historically normal growth rate. In the meantime, each is able to control cost per beneficiary. Total spending in the Medicare program is go up pretty dramatically. And then there's probably the one to remember, the Board of Trustees, which in its annual report is they do the annual report on Part A solvency. There's 2014 annual report, and they've been updating every year since. But the key thing about this slide, even related to Part A, it's true for all parts of Medicare. There are going to be fewer and fewer workers of tax relative to the number of Medicare beneficiaries that's going to enjoy benefits of the Medicare program. So as time goes on and the generation ages into the Medicare program, the strain of generating tax money either through the trust fund mechanism or through general revenues is going to become greater. The number of taxpayers per beneficiary decline. So that demographic challenge to Medicare, which is that spending, as I said before, is going to reach $1 trillion. And would be about 20% of Medicare, of federal expenditures by 5. We add on to that growth in Medicaid spending, which has been, especially after the passage of the ADA. These trends are easily going to be the biggest driver of growth in the federal debt. There are changes made in the programs, particularly Medicare. Spending a percentage of the federal budget, just Medicare alone, you can see next slide. It's going to be going up, and it's actually going to keep going at a faster rate after we get by 2027. So from the New York Times in 2011, as people were thinking about this, it's going to be cut. That's in full. There's no way to solve the nation's long-standing debt problem without reducing the growth of federal health spending. The question is whether the cuts will be smart ones. So this in quote is one of the two authors of the quote, Ike Emanuel, who was President Obama's primary health care advisor in the initial years of his administration. So, this suggests, and I think it's true, that there's a bipartisan agreement that there have changes in the Medicare program to slow spending because of its long-term potential impact on the federal debt. The interest of that is, we'll talk about a little bit later, is things obviously going on that are going to affect the debt a lot more now. The passage of the if the Trump administration's tax reform bill passes, this is going to add directly to the federal debt over the years. But this has implications for Medicare because the more that debt grows no matter what's responsible for it, the more pressure it's going to be to cut back on spending. And Medicare, which as I said, is going to be about 20% of federal spending, is going to be a big target. Okay, the Medicare, in terms of just trying to keep its financial footing, is that Congress looked to Medicare as a source of funding for other programs. And it was particularly clear under the Affordable Care Act, where the Affordable Care Act is going to be funded in Medicare spending of $500 billion over 10 years. Whereas that, where all politicians say they're going to reduce fraud, waste, and abuse, so some of it would be making Medicare a more efficient program. Most of the dollars come through reduced payments to providers and all payments to Part C plans. So just give a little preview of as the program's financial situation becomes more and more difficult, where the Congress will look to slow Medicare spending growth. And the easiest thing, and the quickest thing, I should say, not necessarily the easiest, is to reduce provider payments. Now, of course, the administration has already proposed that it's going to reduce Medicare spending by $450 billion over the next 10 years, and that will be on top of the $500 billion for the ACA, assuming that ACA is ongoing. So now Max Rickman, who runs a law committee to preserve Social Security and Medicare, apparently Medicare is a piggy bank to pay for everything under the sun, has become the new legislative norm for Congress. Rather than balancing priorities or considering a penny of new revenue, Congress are proposing to once again funnel Medicare resources into unrelated programs and fixes, and this time trade adjustment assistance program, which of course has nothing to do with health care. But as Congress people put forward legislation, they're always looking for ways to balance out new spending associated with that legislation to get a favorable score from the CBO in terms of what will happen if the legislation passes and how affect the budget. So it's become the norm for almost any piece of new legislation that gets passed and adds to the federal budget for part of that legislation to be cuts to Medicare at some point, so to keep that budget balanced. And so on the demographic problems, on top of just the growing debt in general, the notion that Medicare is a piggy bank that can be tapped whenever necessary to help fund other new legislation. This growing difference between the costs of commercial insurance and Medicare, and particularly the growing commercial payments as a function of costs. So, participate in the Medicare program, hospitals, for instance, submit cost reports, and this is their representation of what their costs are. And so you compare the cost reports to what they're getting from private sector health as payment for hospital services and what they get from Medicare. And now they're getting, according to the latest data we have, 50% above costs in the negotiations with private health plans. So this difference between what Medicare pays, which is based on cost reports, and what the private sector pays, which is based on negotiations between plans and providers, keeps growing. So that's a big challenge for Medicare going forward, is it increased pressure on Medicare to sort of follow up that behind that payment rate increase that the provider negotiate with private sector health plans, and of course that some begin to see reduced access for Medicare beneficiaries if they don't. Medicare doesn't up its payments to sort of mimic what's going on in the private sector. MedPAC monitors through surveys access for beneficiaries, and we haven't seen reduced access at this point, but it's certainly something that's going to be more and more of a challenge to the Medicare program in the future. So those are my take on what the four challenges are to the Medicare program right now. And I've emphasized along the way that there's disagreements about how to address these things, depending on which political party you participate in. But Republicans and Democrats actually agree on some things in principle. The meant that Medicare spending growth should not go much above the growth in gross domestic product. So exactly, it's always a matter of debate, but half a percentage point or so tends to be the that you hear in that debate. There needs to be care redesigned to help control costs of chronic illnesses and for end-of-life care. Necessary agreement on exactly what that should look like. There would be a major effort to reduce Medicare fraud and abuse. Of course, that's a absolutely an article of faith for politicians regarding whether you're Democrat or Republican, is you need to reduce fraud abuse. And then a general agreement that we should move away from fee-for-service toward value-based payment of providers. Just a radio interview report this morning, transcript, that the president of CMS, and she emphasized that Medicare to move towards value-based payment. So it's a concept that the Obama administration pushed heavily, and now there seems to be some support for it in the Trump administration as well. Moving forward, there's been some really good news regarding projections of Medicare spending growth, and the major effect of that is it's taken some political pressure off Congress to actually do much in the near term. It started appearing back in 2014, and this headline from the New York Times gives you a sense of this. They're not a budget buster anymore. Right? Now, the next, the blue was the projection of Medicare spending growth into 2035. The good news, and the projections that were made in 2010 much slower rate of Medicare spending growth. And that as a result of the recession, there was a general slowdown in health spending during the recession. Of course, that was mimicked in the Medicare program as well. So even Paul Crook, a liberal columnist in the New York Times, had a time that said the Medicare miracle, and he talked about the slower rate of growth in Medicare spending that's projected. And of course, Forbes magazine, a much more conservative media outlet, came up with the headline, "The New York Times is wrong. That's still a budget buster." Forward in time, in thinking about changes that can be made in the Medicare program that could improve quality at the same time return the rate of growth in Medicare spending. A lot of changes are probably technical in nature. They can be administered with CMS. A lot of them don't require legislation. Some do. Many of these changes is very difficult, even if they have a relatively small effect on spending of Medicare. They will have large effects on special interest groups. And it's been amazing for me in my capacity of Vice Chair of MedPAC to watch the special interest groups against some of the changes that we have proposed. The political problem here for legislators is these relatively small changes in total, even if they make absolute sense, and we hope that all of our suggestions make sense, have big effects on special interest groups, and things that are generated are diffused across taxpayers as a whole. So you have people lobbying very aggressively against changes, and you have people that are lobbying in favor because the benefits for those changes are distributed across all taxpayers, and most taxpayers are uninformed about what's going on, and the impact of what's going on would have a small impact on their tax bill. So this is sort of a fundamental thing in any political environment, not just Medicare. It's very to get this enacted practical in nature because of the imbalance of political interest and power. So here, I just randomly put here on this slide that back up what I'm saying. Tom Foley was a CMS administrator under President Bush, and his quotes go through every single payment system in Medicare. Each one is highly political. Zuckerman, who does health policy analysis for the Urban Institute, when you're creating winners and losers, the losers will cry pretty loudly. And then German, and Democrat from the state of Washington, what I thought was a very good statement. People cannot not be affected by the money that comes in through campaign contributions. You know that at the end of the day, the donors are keeping score. So this is a public program. People express their preferences for how the program should be run and how it should be designed through their political representatives. And they then, you're facing all the challenges that any political system faces in trying to make changes which may be for the greater good, but we end up have an adverse effect on different constituents. So moving to why reforming Medicare spending is so difficult. This because it's a quote from the Fiscal Times, which isn't even a U.S. newspaper. And the United States Senate, in the United States Senate, divided over some lines. Senators have come together on not one, but 2 points, a rare agreement. First, the Senate Finance Committee all agreed that Medicare costs must be brought under control. Second, they tacitly agreed in a hearing Tuesday that nobody wants to take the political risk of implementing a major change that might actually help reduce spending, and this is the conundrum. What's the political environment for changes under the Trump administration? President Trump said he was not going to change Medicare. Very about that. But then people to positions within the administration who had well-known roles and positions around wanting to change Medicare. Within the Senate, which are both Republican, the leaders of the committees that oversee Medicare also were people who have been very active in promoting changes in Medicare over time. So not unlike a lot of things that have happened in the Trump administration, this is up to be a conflict between the President said during his campaign and subsequently and what the people in Congress have wanted to do. There are potential for Medicare of repealing the ACA. Long discussion this summer about repealing is really focused correctly on what impact it's going to be on people who health insurance and government spending by states and federal government, the Medicaid program. Has a long-standing proposal we'll talk about in a second to change Medicare, but he has a sense of some of the media responses to Medicare under the Trump administration. So there's a very old columnist for the LA Times who writes here. He's knowledgeable about health care. And this call, Ryan is determined to gut Medicare. This time he might succeed. Because under the Trump administration. This magazine writes about how Trump may remake Medicare. Battle to change Medicare is brewing, whether Trump wants it or not. So here is that even though in the campaign President Trump said he wasn't going to change Medicare, there's be a lot of feeling that Medicare will be changed under the administration in some way. Congressman Ryan would have changed is ironically to Medicare something very similar to the marketplaces in the ACA that the Republicans have opposed. Like to convert Medicare from a guaranteed set of benefits for beneficiaries, regardless of cost, to a money that per beneficiaries would have every year, and that to buy coverage from private health plans. Now that's a very oversimplified version of the Ryan proposal. We have been writing chapters in our annual reports on this proposal. We're trying to sort of draw out the details with the implications of designing it in one way or another might be. The overall notion is that this competition among plans would strain cost growth. And be that the current contribution that beneficiaries would receive would go year at the same rate that gross domestic product went up, plus 7% depending on the proposal. If you're concerned about growth in Medicare spending, the more you're going to tie the increase strictly to GDP. Well, Medicare costs go at a faster rate than GDP, at least in the past 50 years they have. Seems as that over time, Medicare beneficiaries would be paying a greater and greater share of the cost relative to the government share. And design to shift some more financial responsibilities to beneficiaries. And now bids, these competitive bids that health plans submit to participate in this competitive market, at growth targets we've just talked about. The Congress should have to turn around and try to reduce Medicare expenditures by other means. And presumably they would look at the same areas that the Obama administration has proposed, seeking to take $500 billion out of the Medicare program to fund the ACA. And a slide which lists, now the numbers were estimated numbers at the time. I wouldn't place things in them at this point, but an example of the areas where in the future, if the Ryan proposal comes to play and is passed, it's going to likely eliminate the need for most of these things as well. You know, the sort of continual debate about should Medicare be allowed to negotiate pharmaceutical discounts with drug companies. You remember before he was elected, President Trump said absolutely. And within 2 weeks after he was elected, he was visited in the Oval Office by representatives from the pharmaceutical industry, and he came away saying, you know, the best way to reduce drug costs is to try to promote competition among drug manufacturers by extending patent lives. So on that particular issue, change payment formulas to different areas, skilled nursing facilities, home health care areas have had 10 to 20% margins on the Medicare business over the last many years. The ACA is always in the politics of the discussion. It is a salient political proposal. It is the same thing done for Social Security in the past. So it's done. Restricting supplemental coverage for deductibles and co-insurance, and we can go down the line here, but most of it requires reduction payments to providers, as I said before. If you did the ACA, what would the financial impact be on Medicare? It would increase Medicare costs. Ironically, repealing the ACA would increase Medicare costs because as part of funding the ACA, there was a 2% reduction in Medicare payments across a variety of different provider groups. If you repeal the ACA, you lose that 2% reduction, so Medicare spending would go up. Other possible impacts on Medicare if they were to be repealed. And by the way, that discussion is not going to end. And if repealed legislatively, there's a good chance that most of it will be repealed administratively. So it's relevant to continue to talk about ACA repeal. The repeal of the ACA would mean that beneficiaries would go back to paying a larger share of their drug costs under Part D. That's the first bullet refers to. They would get free screenings for beneficiaries for diabetes, heart disease, and cancer. Tom Price, who is, as we know, as head of the DHS, proposed that in his version of the ACA repeal legislation. It would Sarah Palin's death panel, independent payment advisory board, which would be called to action if Medicare expense growth exceeded predetermined amounts. What it would do to the program within Medicare, CMMI, and what would in terms of to implement these payment alternatives. When Representative Price was head of DHHS, he stopped some of the programs that were moving payment towards bundle payments for some surgery procedures. The unknown here is that 20% of Medicare beneficiaries are what are called dual eligibles. So they are Medicaid and Medicare beneficiaries. So if you feel the AC, anything that affects Medicaid, and those beneficiaries is going to have an effect on Medicare, and it's until we're able to see what the design of the repeal of the ACA legislation would be, it'd be hard to predict its effect on Medicare. But a lot of the federal government now is taxing the rules on state Medicaid programs and how they manage Medicaid. So we're going to state-by-state changes in the design and management of Medicaid programs that will affect the dual eligibles, and will revert back to the Medicare program. The other under the Trump administration are also going to have indirect and sometimes not so indirect impacts on Medicare. In budget, there's increased spending for infrastructure, maybe not as much as was anticipated, and increased spending on defense. And then, of course, tax bills going to result in major reductions in revenue. We have a big reduction in revenue and an increase, a resulting increase in the federal debt. Congress will start looking around for ways to counterbalance that. Of course, Medicare, because it's such a big thing item in the budget, is going to be where they'll look. So there's got to be spending to reduce pressure to reduce spending. The present tax reform bill passes. There's no question about that. And then Medicare's fundamental demographic challenges just keep going along. And we keep having people a day entering the Medicare program. And expenditures up no matter what we do on our expenditure growth. And reducing growth in Medicare expenditure is harder and harder. It isn't hard enough in this present political environment. So the October 2017 report, key thing about the report is that there have been in the past 2 public trustees of the Medicare Trust Fund, that's the Part A Trust Fund, and they every year in submitting their report to Congress about the solvency of the trust fund. Those positions have not been appointed yet in the Trump administration, but the 2 people most recently, the public trustees, came out with a joint report in which the time is running out to fix Social Security and Medicare. Further days could mean deeper cuts in benefits or increases in taxes or both. And as we're looking at, the longer we delay in trying to these fundamental financing problems of Medicare, the difficult they will be in the long run to address, and the consequences for beneficiaries and, frankly, for payments are going to get more and more dramatic. So I guess where I'd like to finish my remarks today, and we have some questions, so I'll read you and then I'll try to comment on them. It's great to see some of these names of people who were in class. Just ask Heidi, do you want me to read the names of the people?
Yeah, I think that would be nice.
Okay.
Thanks.
So you ask, what is the best way for us administrators to provide feedback to CMS about topics, provide feedback to MedPAC? Absolutely, you're allowed. The best way to actually enter into this discussion is to provide feedback to MedPAC. All your associations do. In our public meetings, the rooms are packed with association representatives. So if you're a hospital administrator, the AHA is very frequent provider of opinions and information to MedPAC. That's a very effective way to do it. Probably and some effective way to do it than going to a particular congressperson's office and trying to get a time with a staff person. You can do that, but I think making your case to MedPAC is a good way to do it. And even if your association is doing that, write a letter, set up an appointment with our staff. You come to a public meeting and we have a comment period at the end of the meeting. That's probably the worst way to get information to MedPAC, because you're only 2 minutes. This is also from Lad. You mentioned that MedPAC concluded that MIPS is beyond redeeming. What led MedPAC to that conclusion? We didn't think it would result in improved quality at all. We didn't think the quality measures were good to begin with. We think of having physicians out of some 300 measures pick 3 that they want to be measured on. Isn't a good idea? And in fact, the NIA is giving seminars now that say measure one patient, and some, I forget the last part, financially beneficial to you, which means they figured out a way to with a system so that you only have to report one measure on one patient and qualify for your increase in payment. A system that allows that kind of stuff to go on doesn't seem to me to be useful. So to clarify your comment, the ACA will be eliminated administratively. Well, it is being eliminated administratively in a sense because the period has been reduced from 3 months to 1 month. The fund for outreach activities have been reduced by 90%. We can just go down the list of things that right now President Trump has said that he's going to, if he doesn't get of the individual mandate as part of hooked onto the tax reform bill, that he's going to do it administratively anyway. So so all, if you just go down the road, all these different components for co-payments and deductibles for low-income beneficiaries. They've been proposed. So there's a tremendous amount you can do administratively to features of the program, which will eventually result in its demise, in its effective demise. And what we'll have left is, for a while at least, is federal government increases in federal government subsidies to state Medicaid programs that have decided to expand. Those subsidies, of course, are time limited. So there's just a lot of forces right now that are changing the program in ways that I think are going to make them not sustainable. Okay, the Financial Alignment Initiative for Medicare and Medicaid beneficiaries show hope of helping to control costs under both programs. Great question. I'm not sure. I have an opinion on that, Steve. I'm sorry. Not a very good answer. I just don't understand what the effect of that is going to be very well. And demographics and the rate of people aging into Medicare. How do we reconcile that with the report slide showing the rate of growth slowing over time? Well, it's going to slow over time, of course, as the baby boom generation effects start to diminish. And there's in these projections slower rates of growth in provider payments. Projections like you see are based on a whole set of underlying assumptions. Well, they all are. And makes the assumptions depends on where you want the projections to end up. So positive or negative effects on these things depending on the assumptions. The assumptions you saw on that slide, I think, were basically extending the slow rates of growth that existed before or during the recession and saying, well, we're going to ramp up to similar rates of growth that existed before the recession. And the control, not controlling comments.
Oh, from his earlier question.
From the earlier question. The question, what role will the AARP play in the future structure and funding of the Medicare program? Well, he is an advocate for better coverage, greater for beneficiaries. And I think in the one, they always play a role in the margin. Pure guess on my part, but I think the financial considerations will make it more difficult for the to pursue some of their agenda items for Medicare. And then CAF, MACRA, MIPS will eventually go away. Not sure about the MACRA part. The MIPS part, boy, it had better be revised substantially. We've had a small industry now that's grown advise physicians how to move well under that system, and so they've become a substantial lobby against eliminating MIPS. So you're trying to revise substantially the bill, as I said before. That was one of the two pieces of bipartisan healthcare legislation which has been passed in the last 5 years. So you have 6 people that are involved in passing that legislation that feel pretty good about it. So now telling them that they need to consider eliminating part of it or revising it is a tough follow. But we just thought MedPAC commissioners and their public statements. And by the way, transcripts of our meetings, which are posted on our website, so we can say how people were feeling about it. And they generally felt that it really needed to go away. So what they realized the political difficulties of this, but one of the things that MedPAC does is put these difficult issues on the table. That's what we hope to do. So we're even on the recent release of the CMS OPPS rules, particularly reduction of reimbursement for drugs when purchased using 340B. Yeah, very complicated issue, and MedPAC has in generally supported rethinking the 340B rule. And so I would, in terms of comment, I'm not sure. I would say issue around this, of course, as we all know, is that if a fairly large number of income people in your facility, you're allowed to purchase drugs to serve those people at discount rates. And the question here is power been used appropriately? There's some evidence that hospitals get discounted rates for the drugs paid for across the board for different people who are in the, including Medicare beneficiaries. Then they turn around and charge Medicare beneficiaries a rate for the drug which is the rate and not the discounted rate. We don't think that's fair to beneficiaries of the Medicare program. Comment on it would be, I think it's generally a movement in the right direction, but there's got a lot of further discussion about this. And John, the ACA is repealed, will DISH and GRE payments be restored fully or in part? Well, if it's a repeal of the ACA, yes, they would be. We haven't seen any legislation that would be a pure repeal. And Jennifer, is any hope that the negotiating with the drug companies will be revoked with the administration? I think the discussion of negotiating will be revived. It has a lot of public support. I don't think people really understand what they're. I actually don't think direct negotiations with the drug companies would have a huge impact on the Medicare program. So I can be revived. From what I've observed in terms of the ability of the pharmaceutical industry to lobby successfully for its goals, I would be skeptical to actually see negotiation, any legislation that allowed negotiation. It requires statute. You'd have to have legislation that actually Medicare to do this, and see that happening in the next year or two anyway. I mean, we're already in the next election cycle, as you did. Medicare is a pretty kind of program making changes. It's not a traditional program making changes. There tends to be very controversial. So I'm sure that they will want to bring up before the midterm elections any major changes to Medicare. Again, say they support negotiations, but whether they pass legislation that would allow it is, I'm skeptical, I guess. Medicare for all. If you accepted the premise the single-payer system was the best model, do you think Medicare would be the best vehicle to accomplish it? Boy, that's a great question. Medicare for all. So I'm not sure people really understand what Medicare for all it would entail if you took that phrase at its face value. So it's not result in a centralized government-run healthcare system. I kind of sense, listening to the comments from Senator Sanders, that's kind of what he's telling people. But I mean, you think about the Medicare program as I've just described it to you. A third of beneficiaries now in private health plans, growing. We interact with regional administrators to administer the Medicare program. We have drug plans that provide Part D coverage. So it's an interesting mix between the public and private systems. So would Medicare be the best vehicle? The quickest vehicle would be Medicaid, because we have a larger percentage of the population in Medicaid now than we have in Medicare. But the bad is that there are really 50 different Medicaid programs, not one. So we have the issue of how do you bring all the rules, regulations, and together, and how would you move things away from a state-based program to more of a federally centered program. So a quick path to a centralized healthcare system that would cover everybody, and Medicare for all is a good step if you want to go in that direction, because people have a better sense of Medicare, what it means, than they do of other programs. And also, as I said before, it's extremely popular politically. So, the reaction of people when they first hear this is, yeah, this would be a good idea. I think it would be quite. If it happened, it would not evolve quite the way people imagine. So back to lab. What are MedPAC's thoughts on CMS moving to capitation fixed payment per beneficiary within traditional Medicare. Well, we are not in the business of advocating for political actions on issues. We have a lot of time sort of slicing and dicing the proposal and figuring out what it really means and what kind of geographic just transfers money would entail if that happened, and how the bidding process might work, and so forth. So what we've been trying to do is address some of the issues and applications so that if Congress decides to go that route, they'll do it with their eyes open and what some of the implications would be. So for or against that, we are for Congress the best way that we can, and we think the best way we can do that is to spend time sort of working out all of the details of such a program. Well, we've done that very well over the years, and we'll continue to do that. Okay. Is there any discussion of eliminating inpatient versus observation in hospitals or other billing complexities as you use value-based reimbursement? Yeah, as you move towards value-based reimbursement, particularly if it's a think of it as bundled payment. Under bundled payment, you have taxation of those rules. We would. So yeah, I think there would be. I think the more that you put financial responsibility on the group for a particular group of beneficiaries, the more the beneficiaries, the more flexibility you have to give them in terms of how they want to manage their care. And we have a current student in our program. If with hospital debt rise because less people are covered, and you have fewer people covered, that's not a good thing for hospitals. So you do the number. If you reduce Medicare the 65 to 67 things, you have fewer people in the Medicare program. So then is what becomes of those people between 65 and 67. So if we the ACA, they don't have an option, so they're going to get into the individual market, try to buy health insurance. Because of which they're going to have to pay a lot of money to buy health insurance in the individual market. So a large number of them may qualify for Medicaid. So more people who are uninsured and more people who are insured under Medicaid, which is a worse payer for hospital care than Medicaid. So talk about reducing coverage for beneficiaries, Medicare beneficiaries. It's hard to construct a scenario in which hospitals are going to be better off as a result of that.
Dr. Time for one last question.
Okay. Let me read real quickly. What will benefit from encouraging more skilled immigrants to bolster our declining workers per HSI beneficiary? The thing that increases the number of people in the workforce earning higher wages than they do now, or just stimulates the economy, is going to result in more contributions to Part A, and it's going to help the trust fund issue. And ultimately, as economic growth and GDP increases, tax revenues would follow. That's not necessarily going to help Medicaid because they're Medicare, because so many competing interests around how that tax revenue will be spent, and given the projections for increase in the debt, both in the economy is going to try to pay that. So it's hard to see how it would affect the Part B and D. It would have a positive effect on Part A. For hanging in there for this question and answer period, and please these names here with questions and bring back familiar faces from my classes, and I hope all is going well for all of you.
Thank you, Dr. Christianson, for the time and information that you so generously shared with our alumni and friends of the program today. And everybody that joined us on the webinar, thank you for your participation. I'd encourage you to please complete the survey that will arrive in your inboxes after you close out the webinar. That will help us on the Engagement and Education Committee understand what other topics you'd like to hear about webinars through the year. Thanks again, and have a great rest of the week.